So now the guidelines, of course, deal with many aspects of management of bipolar disorder. It, in fact, has 8 different sections, ranging from talking about the diagnosis to managing bipolar disorder in special populations, bipolar II disorder, safety monitoring issues. So for me to take you through everything that's in the guidelines will probably take all day, which I don't have. So I only have about 45 minutes, I think. So what I'm going to do in the next 45 minutes is to take you through some of the highlights in managing, or some of the key changes in the management of acute mania, bipolar depression, and maintenance treatment of bipolar disorder. So those are the 3 things that we're going to try and focus this morning. So as I said, we published the guidelines for the first time in 1997 in Canadian Journal of Psychiatry. Over the next few years, as the data became available, we wanted to continue publishing the guidelines, but we also wanted to make sure that the guidelines that we publish are not only relevant for practice in Canada, but also internationally. So that's one of the reasons when we published the full version of the CANMAT guidelines in 2005, we decided to go international. So we actually published those in the Bipolar Disorders Journal, which is an international journal. And in that publication, what we also did was we asked bipolar experts from different continents, Asia, Africa, South America, Europe, to write commentaries about the CANMAT guidelines, basically looking at what aspects of the guidelines, the CANMAT guidelines, are relevant for practice in their parts of the world, and are there things that they do differently that other people could learn from. The idea being that if we understand the patterns of practice in different parts of the world, eventually we could move towards publishing guidelines that are relevant for practice everywhere in the world. So that was the original objective. So that's what we did in 2005. And then we updated these guidelines in 2007. When we did the update in 2009, because of the international relevance, we wanted to make sure we included experts, bipolar experts from other parts of the world as authors, so that when we published these, that these would be relevant for practice in different parts of the world. So what we did was we selected, or we invited experts from the International Society for Bipolar Disorder from different continents as co-authors of these guidelines. So in 2009, when we published that update, that was published in collaboration with the ISBD, and we did the same thing in 2013. So our last update was about 4 years ago. And as we presented these guidelines at different conferences and different countries, one of the things that we've kept hearing from psychiatrists around the world is that they like these guidelines, but with these updates, they started saying to us, look, you know, when we read 2013, there are things that you refer to about in 2005 guidelines, so then we have to go back and look at those. So maybe it's time for the CANMAT group to publish a full version. And so we heard that feedback. So for the 2018, the next version of the guidelines, it is going to be a full version so that you actually don't have to go back and refer to 2005 or 2007 or 2009 guidelines. So this is going to be a complete revision. And the new guidelines are going to be published in collaboration with the ISBD, which means we are going to have bipolar experts from around the world as co-authors on these guidelines. As with the previous guidelines, people seem to like the format of these guidelines. So the new guidelines are also going to have 8 sections, which address various aspects of management of bipolar disorder, ranging from, as I said, diagnosis to managing mania, depression, maintenance treatment, bipolar II, special populations, and finish off with the safety monitoring issues. So before I talk about the specific aspects, let me just take a couple of minutes to tell you about the process in terms of how we arrive at recommendations. Now, in terms of how the process, it's fairly similar to what we did with the previous guidelines with some minor changes. So one change being, if you look at the level 1, for example, it says meta-analysis with narrow confidence intervals are replicated double-blind randomized trials that includes a placebo or active comparison in each treatment, which is exactly what we had in our previous guidelines. The new change is that we've actually now specified the sample size for each treatment arm. The reason why we did that was because in the past, so let's just say there's a medication which is being tested in 2 double-blind trials, and each of those trials had 200 patients, right? And both those trials showed that the medication is effective. Now, you can put a lot of confidence in that result. Now, you take another medication, which also was studied in 2 trials, and each of those trials had 15 patients, right? And both trials show that the medication works, and they came from a single center. Now, with the previous criteria, both of those would have been rated as level 1 evidence for efficacy. And we thought that's probably not appropriate because the amount of confidence that you would have when you have a result from a study that had 200 patients is quite different from a study that had only 10 or 15 patients. And for that reason, we've decided it's important to specify a sample size in each arm so that we can determine the confidence, so that we can have more faith in terms of the result of the trial. So that's one difference in terms of how we evaluated the criteria. When we translate these recommendations into these criteria for evidence into recommendations as first line, second line, third line. So previously we had, so for first line we had level 1 or level 2 evidence plus clinical support for efficacy, safety, tolerability, which is exactly what we have now as well. But the main difference is that in our previous guidelines, we didn't show you a rating for the safety and tolerability. It was almost like a black box. We said we took that into account, but you as a reader didn't actually see that. So in our new guidelines, we're now actually assigning a specific rating for the safety and tolerability, both for the acute phase and the maintenance phase, and we're also including a new category, which is the risk of treatment emergent switch, in terms of a switch into a manic episode and also depressive episode, so that we are showing that, so that you know how we've taken that into account in arriving at a recommendation. So those are the sort of 2 significant changes in terms of the process. So to give you highlights of the other highlights of these guidelines, so one is, as we said, there's more rigor in terms of evaluating the evidence. And secondly, as I said, we are now assigning a rating for the safety and tolerability. And then we take all those things into account to arrive at whether a given treatment is a first line or a second line. The other important change in the new guidelines is that we've taken the view that bipolar disorder is a chronic disease, like diabetes, because it's seldom that you have someone that has a manic episode and then they're stable for the rest of their lives, right? They keep having manic relapses and depressive relapses. So we've taken the view that given that, when you're selecting a treatment for a particular phase of bipolar disorder, you want to select a treatment that not only works for treating that particular phase, but also for other phases of the illness. So in other words, let's say you're trying to decide a treatment for someone with acute mania. And if you had 2 treatments, both have been shown to be effective for treating acute manic episodes. But if one of that treatment also has been shown to prevent manic episodes and depressive episodes, ideally you would want to use that treatment ahead of the one that just was shown to be beneficial for acute mania. So that's the sort of view that we've taken in these new guidelines. So looking at the management of the disease of all the phases and taking the evidence for efficacy of the treatments for various phases, we are now ranking even among the first line and second line in a hierarchical way, implication being that you want to try the treatment that is higher up in the hierarchy, given all things being equal, before you go down to the one next on the list. Also, as we reviewed the evidence, and those of you that have been following some of the literature know that there are situations where the evidence is controversial. So in other words, sometimes you look at a particular treatment and there may be 3 or 4 studies. 2 studies show it works, and then 2 studies show it doesn't work. Then what do you do with that kind of stuff, right? So in those situations, we wanted to show you how we are actually arriving at the conclusion in terms of whether we are recommending that as a first or second line treatment. So we now created text boxes within those guidelines where we say, okay, here's a treatment where the evidence is conflicting or controversial. This is how we are actually resolving that controversy. This is our line of thinking, and this is how we arrived at a recommendation in terms of the efficacy rating for that particular treatment. So we've done that. And then we've also introduced a new category called no specific recommendation category. And we've done this because, again, there are situations, and I'll show you 1 or 2 examples, where from the pharmacological perspective, and by taking into account the evidence from some of the other studies, you would expect a particular treatment to work. But then you look at the study, it didn't work. That doesn't make sense. So can you just conclude based on that particular trial, when everything else tells you that's not right, that you don't recommend that treatment? So we've actually taken the view, in those situations, maybe we need actually more studies, we need more data before we can actually make a specific recommendation about the treatment. So to have a place for those kinds of situations, we've actually created this new category called no specific recommendations category. So let me show you some of these examples then. So I told you that we've created a rating for the safety tolerability. So I don't expect you to go through the full table here, but just to illustrate that we've rated for each treatment in terms of the safety during the acute phase, safety during the maintenance phase. Same thing for tolerability during the acute phase, on the maintenance phase, and then, of course, the risk in terms of the treatment emergent switch into mania or depression. And those pluses indicate the impact that safety tolerability would have in treatment selection. So 1 plus is minimal impact, 2 plus is significant impact, and 3 pluses is obviously bad. So that's how we've taken that into account. I talked about the hierarchical rating. So you can see for acute mania, in the first-line treatments in monotherapies, you see lithium, quetiapine, divalproex, et cetera. So those circles show you the level of evidence for each of the treatments. If the circle is full, completely filled, that means it's a level 1 evidence. If the circle is 3/4 filled, it's level 2 evidence. If it is half filled, it's level 3. And then if it is quarter filled, it's level 4. So it's a good way, instead of you going through all the studies, you just look at it and say, for lithium, for example, for acute mania, it's got a level 1 evidence because the circle is full. Prevention of any mood episode, level 1 evidence. Prevention of mania, level 1 evidence. Prevention of depression, level 1 evidence. Acute depression, it's got 3/4. Now, this is one of the controversial issues, and we've addressed that. You might be thinking that, well, what studies actually suggest lithium works for acute bipolar depression? There is some controversy about it, and we've addressed that in the section, in the text box where we resolve this conflict. So that tells you, if we actually follow those things down, you will see the ones that had the best evidence are the ones that are higher up in the hierarchy. So the implication of something like this is that if you have a patient presenting with acute manic episode for the first time, and the patient has not tried any treatments, given all things being equal, you would want to start that patient on lithium because it's got the best evidence, right? But if the patient has already tried lithium and it didn't work, or if the patient had a family member that tried lithium and didn't work, or if the patient has mixed features, then you might say, okay, well, maybe not lithium. Maybe I go down to the quetiapine or valproate and that kind of thing. So the idea of it's almost like managing diabetes. If you have someone that's diagnosed with diabetes for the first time, you go to endocrinologist, they'll say, well, let's use the diet strategies, exercise first. If your blood sugar is not controlled, then most endocrinologists will put you on metformin as a gold standard. And if your blood sugar is not well controlled, then they go down the list by adding other things. So we're basically taking a similar view. bipolar disorder is like any other chronic medical disease. So we really have to start thinking about the entire illness, not just focus on the phase that you're trying to manage. So here is a text box. So why are lithium and lamotrigine recommended as first-line agents for bipolar depression, reconciling conflicting data? So you can see if you go through that information, you'll know why we still put these medications as first-line treatments. So I said there's no specific recommendation category. So here are a couple of examples. So ziprasidone and paliperidone both have strong dopamine 2 receptor blockade properties. Every medication that blocks dopamine D2 receptors works for treating acute manic symptoms, no exception. Everything that blocks D2 works for acute mania. Both ziprasidone and paliperidone have been shown to be effective in treating acute mania in monotherapy. So if you give them on their own, they treat acute mania quite effectively, better than placebo. But there are studies where when ziprasidone is given in conjunction with lithium or valproate, that combination is no better than giving placebo in conjunction with the mood stabilizer. That makes no sense. Because if you use risperidone or quetiapine or aripiprazole or asenapine in conjunction with the mood stabilizer, that combination is better than giving placebo plus mood stabilizer. And yet, for some bizarre reason, ziprasidone adjunctive therapy didn't work. And these things happen sometimes depending upon where the studies were done, what kinds of patients were recruited into the trials, because of those methodological kinds of issues. And that's why we said, based on that, we can't say don't ever use ziprasidone or paliperidone in conjunction with lithium or valproate. They probably work. So that's why we put those in those no specific recommendations category, basically saying we may need to do more studies to understand that. So those are some of the key highlights in terms of new guidelines. Now let's go through management of the specific phases, the acute mania, depression, and maintenance. So here's what we said in 2013 treatment guidelines for bipolar disorder. And as you can see, asenapine clearly works, and it was actually one of the first-line recommendations even in 2013 guidelines. It was new at that time, the data was new, so it was included as a first-line recommendation. And in the third line, you see tamoxifen. Now, tamoxifen is a drug that's used for treating breast cancer. The reason why tamoxifen was studied was because it inhibits an enzyme called protein kinase C, which lithium inhibits as well. So based on that, there are about 3 double-blind placebo-controlled trials that looked at the efficacy of tamoxifen in treating acute mania, and it does work. But the problem with tamoxifen is that it increases the risk of uterine cancer. So we're not going to recommend using tamoxifen for treating acute mania, given that we have so many other treatments. So it'll be down the, maybe third line because we have so many other effective treatments. Now, in the not recommended category, you see topiramate. And that's because, so topiramate, as we know, is an anticonvulsant. And in early 2000, when we learned that valproate and carbamazepine worked for treating acute mania, we believed that every anticonvulsant basically worked for bipolar disorder. And since then, we've learned that that's not the case. And in fact, with the topiramate, there are 4 double-blind placebo-controlled trials, 2 of which also had lithium as an active comparator. In all those 4 trials, topiramate did not treat mania. And in the 2 trials, lithium was an active comparator. Lithium did improve mania. So we know topiramate does not treat manic symptoms. But what those studies did show was that topiramate causes weight loss. So that's clear, but it does not treat acute mania. So the answer for that question was tamoxifen. But there was also another drug on that list, which is cariprazine. Sorry, topiramate, I mean, yeah, topiramate does not treat mania. But there was another drug on that list called cariprazine, which we don't have in Canada as yet. It's a new atypical antipsychotic. It's a D2, D3 partial agonist. Just got approved in the US for treating acute mania. And this slide shows you the results from 3 double-blind placebo-controlled trials. And as you can see, in all 3 trials, the response rates for cariprazine were greater compared with response rates to placebo. So basically, cariprazine is effective in treating acute mania, and at some point in the future, it will become available in Canada for acute mania. In terms of the side effects of this medication, the main thing to watch out for, like aripiprazole, as we said, it's a partial D2 agonist. So akathisia is one of the things to watch out for. But things like weight gain and metabolic issues are not a significant concern. So that's the only thing to remember about this medication. So as I mentioned, we've used this new way of assigning the ratings. So here is a legend for ratings, level 1, level 2, level 3, level 4 evidence. And I'll show you how the acute mania recommendations look like, which you've already seen before. And as you can see now, cariprazine is listed as one of the first-line treatments because it does work for acute mania. And I'll show you some data for cariprazine for acute bipolar depression as well. The other changes in these guidelines are we've downgraded olanzapine to a second-line treatment, both monotherapy and also adjunctive therapy. And that's mainly because of the safety tolerability issues. As we looked at the ratings in terms of safety tolerability, we felt that given it causes significant weight gain, metabolic issues, although it is very effective in treating acute mania, we felt that there are many other safer treatments that we could use for treating manic patients before you think about using something like olanzapine. So I won't go through the list, but there are no substantial changes other than addition of cariprazine and downgrading of olanzapine and monotherapy in the combination. Here is a list of third-line recommendations. As you can see, tamoxifen is a third line. When you're managing someone with acute mania, you seldom actually go to third line because there's so many first-line, second-line options. So most patients with acute mania do end up getting better with some of the first and second-line treatments. So this list is only there if we had an odd patient, which seldom happens, that hasn't responded to all the first-line, second-line, then you might think about some of these things. And you can see the list of not recommended treatments is quite significant. There are number of negative studies. Topiramate doesn't work. Lamotrigine doesn't work for acute mania. Carbazepine, which is another anticonvulsant, doesn't work for mania, and the list goes on. So that's briefly management of mania. And I think the good news with those of us that treat bipolar disorder is that we have lots of options for treating patients with mania. The bad news is that we have very few proven treatments for managing patients with acute bipolar depression. And that's really reflected in clinical practice. And in fact, if you actually look at patients with bipolar disorder and see what kinds of symptoms do they experience more commonly on a day-to-day basis, it's depressive symptoms. Because typically when we think about bipolar, mania is the thing that comes to our minds because bipolar disorder is defined by mania because without mania, there's no bipolar disorder. And yet, in clinical practice, what we see with a lot of bipolar patients is that when they have manic episodes, they get treated, they get better fairly quickly, but when they have depressive symptoms, they're prolonged, they interfere with functioning, they're often suicidal. So treating depression is a big challenge. So here is what we said in 2013, and as you can see, quetiapine is one of the first-line treatments, which means it has been shown to be effective in double-blind placebo-controlled trials for treating acute bipolar depression. Lurasidone was listed as a second line at that time, and that's because there were 2 double-blind placebo-controlled trials, but the data had just come out, and we did not have much experience then, so that's why it was listed as second line. So lurasidone does work, and I'll show you the data in a minute. You don't see cariprazine there, but if you look at the not recommended category, you actually see aripiprazole. And the reason why that was in there was because there were 2 double-blind placebo-controlled trials that looked at the efficacy of aripiprazole monotherapy in comparison to placebo in treating bipolar depression. And in both studies, aripiprazole was no better than placebo. So based on those studies, the conclusion is aripiprazole alone does not work for treating acute bipolar depression. But of course, since then, aripiprazole has been studied as an adjunct to SSRIs and other antidepressants for treating major depression, unipolar depression, and there are studies showing the efficacy, and that's approved. So a lot of the time, people look at this and say, oh, aripiprazole, is effective for treating bipolar depression. That's not the case, because that's unipolar depression, not in monotherapy, but as adjunctive therapy. Now, so let me show you the data for lurasidone then. So as I said, it was second line in 2013 because the data had just become available. Since then, it's been approved, of course, by Health Canada for treating acute bipolar depression. There are a couple of trials published in American Journal of Psychiatry. Lurasidone, like other atypical antipsychotics, also blocks dopamine D2 receptors. So theoretically, it should work for mania, but it's never been studied for treating acute mania, so we don't know. So here are the two studies that looked at the efficacy of lurasidone for treating acute bipolar depression. There's a monotherapy trial which studied two different doses, 20 to 60 milligrams and 80 to 120 milligrams. And as you can see, the response rates for both those doses were almost identical, about 50% getting better versus 30% of patients in the placebo group responding, and that difference being significant statistically. In the second trial, lurasidone was added to lithium or valproate. So these are bipolar 1 depressed patients who had been taking lithium or valproate, not getting better. So half of them had lurasidone added, other half had placebo added, and then when you did that, the group that got the lurasidone, more patients got better compared with those that got placebo. So the conclusion is that it works both in monotherapy and also in adjunctive therapy. And more recently, there was another trial which looked at the efficacy of lurasidone in treating acute bipolar depression in children and adolescents, the age group of 10 to 17. Very similar design, patients, children and adolescents with acute bipolar 1 depression were randomized to get either placebo or lurasidone starting at 20 milligrams, and then the dose was adjusted between 20 to 80 milligrams. It was a 6-week trial, and as you can see, in terms of the changes in depressive symptoms measured using the Children Depression Rating Scale, greater reduction in depressive symptoms in the lurasidone group compared with the placebo group. And if you look at the responder rates, about 60% of patients in the lurasidone group meeting the criteria for response versus 36% of patients in the placebo group. So even in children and adolescent group, lurasidone seems to be effective in treating acute bipolar depression. The other new medication that's been studied is cariprazine, that D2, D3 partial agonist, which I said works for acute mania. So this was studied in, this medication has been studied in 2 different clinical trials. The first trial was a big international trial that we did where we had 3 different arms, 2 different doses of cariprazine and placebo. And this was a 8-week trial. And if you look at the changes in depressive symptoms in blue, cariprazine 1.5 to 3 milligrams, and then you can see the other in gray placebo, and then you also see the cariprazine 0.25 to 0.75 milligrams response in terms of change in depressive symptoms. So basically, it looked like cariprazine 1.5 to 3 milligrams was improving depressive symptoms up until week 6, and then something happened after that. So at week 8, which is the primary endpoint, no difference between the 3 groups. So when we saw the results of this study, it was quite surprising because given that it has a D3 partial agonistic properties, we expected this drug to work, and yet we weren't able to demonstrate the benefit. When we looked at the placebo response rates in the study, we found that 60% of patients actually got better with placebo, which is very difficult to believe, right? Because those of you that treat bipolar depressed patients, and I exclusively treat bipolar patients, I can't get half of my bipolar depressed patients better with all the drugs we have available, and yet in this study, 60% got better with the placebo. So there's clearly something wrong with this study. So the company that used to have the patent rights for cariprazine those days was a company called Forest. So we went back to them and we said, look, you got to do another study because there's something wrong with this study. And most companies at that stage will say, we've spent $20 million, forget it. But this company actually said, okay, we'll do another one. So what should we do? So we came up with the design for another study. So here we had 3 different doses of cariprazine, placebo, and in this second study, we actually did find the 1.5 milligrams was more effective than placebo, and 3 milligrams there was a trend. So based on this now, Forest, which is now bought by Allergan, is doing more studies. So we will know in the next couple of years whether the results from this study actually would be confirmed or not. So for now, it looks like cariprazine, given in the dose of about 1.5 milligrams to approximately 3, appears to be effective in treating acute bipolar depression. The other story with the bipolar depression is the antidepressant story, right? Probably the most controversial issue in the management of bipolar disorder. Because if you ask clinicians, most people will say antidepressants work, and yet in the clinical trials, we've had trouble demonstrating their benefit. Now, sometimes, again, if you do smaller trials with smaller sample sizes, even if the medications are effective, one might have difficulty demonstrating the benefit because of the lack of statistical power. And one way to address that, of course, is by combining the data and doing a meta-analysis. And that's been done previously for antidepressant trials. There were about 3 meta-analyses, 2 of them showing antidepressants work when they're given in conjunction with a mood stabilizer or atypical antipsychotic. In one meta-analysis, there was a trend for efficacy. P-value was 0.06. But one of the problems with these meta-analyses was that these included studies of antidepressant monotherapy. Now, no bipolar expert will tell you that you can use antidepressant monotherapy for treating acute bipolar 1 depression. Bipolar 2, it might be okay, but for bipolar 1, nobody recommends using antidepressant monotherapy. And the second thing is that some of those meta-analyses also included some of the older studies with the tricyclics and MAOIs. And again, we don't really recommend using tricyclics and MAOIs for bipolar 1 depression, mainly because of the risk of manic and hypomanic switch. So for those reasons, we thought, well, although those older meta-analyses suggest antidepressants might work, really they don't, you can't translate that for clinical practice because of those issues that I talked about. So we said, if we really want to understand whether antidepressants work or not, antidepressant adjunctive therapy, you really want to combine the data from studies that looked at the efficacy of second-generation antidepressants like SSRIs, bupropion, which is what we did last year. And we published this paper in Lancet Psychiatry. And basically, this is what we found. So when we combined the data from studies that looked at the second-generation antidepressant adjunctive therapy, we did find that there is efficacy. But if you actually look at the effect size, I can't point out, I guess, but it is about 0.165. So that's the magnitude of benefit for antidepressant adjunctive therapy, which is actually quite small. Because typically, if you think about the effect size for something like lurasidone or quetiapine, it's usually about 0.6 to 0.8 in that kind of range. And compare that with the antidepressant adjunctive therapy, it's 0.165. So the message from our study was that antidepressants probably work, second-generation antidepressants, but the magnitude of benefit is small. Now, in our studies, we also looked at, in our meta-analysis, we also looked at the switch risk, because that's one of the things we are concerned about, right? When we use antidepressants, do they switch patients into mania or hypomania? So we looked at the switch risk during the acute phase within the first 6 to 8 weeks, and the switch risk if we continued the antidepressant after the patient got better, what happens? And what we found was that during the first 6 to 8 weeks, the switch risk was actually not a problem. There was no significant increase in switch. But when we looked at the 2 studies that followed patients up to 1 year, and one of them was our agomelatine study, there was a greater incidence of manic, hypomanic episodes in patients that continued antidepressants for 12 months versus those that were taken off the antidepressants. So the message about the antidepressant story is that they work, but the magnitude of benefit is small. But if you have a patient who gets better, the risk may not be a concern during the acute phase, but don't continue the antidepressant on a longer-term basis, because if you continue it long enough, you might switch them into mania or hypomania. So with that, when we pull all that stuff, this is how the new bipolar depression recommendations look like. So you can see quetiapine, lurasidone plus lithium or valproate, lithium lamotrigine, lurasidone monotherapy, and then lamotrigine. And you can see second-generation antidepressant adjunctive therapy is now downgraded to second line. It was first line in our previous guidelines. We moved them down to second line, mainly because of the smaller magnitude of benefit and the longer-term risk of switch. You also see ECT in there as a second line. It was a third line in our previous recommendations. And that's because, as I mentioned, it's so difficult to get bipolar depressed patients better. And there's a study recently that came out of Scandinavia which showed in refractory bipolar depressed patients, if you randomize them to ECT versus other medical treatments, ECT beats them hands down. So ECT is still quite good. So provided patient and the family is willing to accept, ECT is still a good option for patients with refractory bipolar depression. Risperidone Consta has been shown to be effective in preventing mood episodes. There are double-blind trials. Aripiprazole once monthly injectable. There is a study, and I'll show you in a minute. Paliperidone oral tablets for prophylaxis. There is a maintenance study, and the study does show it's better than placebo. What we don't have is the paliperidone Sustenna studies. Okay? It may work, but we don't have studies as yet. So that's what I was trying to get at. So going back to what we said in 2013, so you can see risperidone injectable was in there as well, and a bunch of others, lithium, lamotrigine, valproate, olanzapine, et cetera. So let's look at what the new data are in the last 3 to 4 years. So there is a study with lurasidone, adjunctive therapy. So in this study, patients with bipolar 1 disorder that were experiencing either manic, hypomanic, or depressive or mixed episodes were recruited. They were treated with lithium or valproate plus lurasidone. If they got better, they went into the double-blind phase. Half of them continued both the mood stabilizer plus lurasidone. Other half had lurasidone replaced with placebo. So it's a fairly typical kind of maintenance design. The only difference is that this study was only about 6 months duration. Most maintenance studies, have 12 to 18 months duration. So that's one difference. The other difference is that the criteria required to get into the open label phase in terms of severity of mania and depression, threshold was quite low in this trial. So those were the two concerns with the design of the study. So the expectation was that the group that got lurasidone in conjunction with lithium or valproate, in that particular group, fewer patients will have relapse of mood episodes compared with those that got lithium or valproate plus placebo. So that was the prediction. And here are the results. This is the time to any mood episode. And you can see the lurasidone group did have fewer patients relapsing compared with the placebo group. But the difference from the statistical point of view was not significant. You can see that p-value is 0.078. So we want that to be less than 0.05. So based on this, we can't say that we've actually proven that lurasidone adjunctive therapy is effective in preventing relapse of mood episodes. Now, one problem with this trial is look at the relapse rates in the placebo group. By 6 months, you only had about 20% of patients experiencing a relapse of mood episode, which is incredibly low because if you look at a bunch of other studies with the similar kinds of designs, by 6 months, about 40% of patients have a relapse. So in this study, the relapse rates in the placebo group were very, very low. And when you have that kind of situation, it's very hard to demonstrate the efficacy of a medication when the relapse rates are low. And that's basically what killed this study. Now, you can also look at, well, what happens if the patient went into the study in a depressive episode and you treated that patient with lurasidone plus lithium or valproate. In that case, if you continued lurasidone, would that be beneficial? And the answer is yes. So patients that were treated with lurasidone adjunctive therapy for index depressive episode, in that subgroup, if you continue lurasidone, it is more effective in preventing relapse of mood episodes. And you can see the p-value here is 0.039. But that does not appear to be the case if you treated a patient who went in with a manic or hypomanic episode, which again is surprising because it's a D2 blocker. So clearly, some of the design issues in this study interfered, unfortunately, with the results of the study. There's also a study with asenapine, which hasn't been published as yet. It'll be published in American Journal of Psychiatry in the very near future. So in this study, patients with manic episode were treated with asenapine, and if they got better, they went into the double-blind phase where half of them continued with asenapine, other half had asenapine replaced with placebo. And if you look at the relapse of mood episodes, you can see relapse in the placebo group in blue and the asenapine group in red. And you can see the difference being highly significant, p-value of 0.001, which means asenapine monotherapy is more effective than placebo in preventing relapse of mood episodes in bipolar patients. So in this case, so that graph includes both depression and mania, but let me show you separately for mania. So here is in the same study, if you look at whether asenapine prevents mania, so you can see relapse rates, the color is gone here, but the line at the bottom is the asenapine group, and the line at the top is the placebo group. So you can see way more patients in the placebo group had a manic relapse, and that's significant. And the depression, again, the line in the bottom is the asenapine, top is the placebo. Again, there is a difference, and that difference is significant. But you can see the magnitude of difference. Mania is much larger. Depression, the difference is there, but it's not as much. So it prevents both mania and depression, but it's much better at preventing mania than it is in preventing depression. Similar study with the aripiprazole once monthly injection. I won't go into the details of the design, but basically, patients who got better with aripiprazole for acute mania were stabilized on the aripiprazole once monthly injection. If they were stable, then they went to the double-blind phase, and in the double-blind phase, half of them continued to get the aripiprazole injection, other half had a placebo injection. And here are the results. You can see relapse rates in the placebo group versus aripiprazole group, difference being significant. This includes both mania and depression together, so any mood episode, right? But to your question, if you look at, again, for aripiprazole, which is what we want to know as clinicians, does it prevent mania, does it prevent depression? Here is the answer. So you can see relapse rates for mania, 12% in the aripiprazole group, 40% in the placebo group. So clearly works for mania. Depression, 20% in the aripiprazole, 19% in placebo. So it doesn't do a whole lot for preventing depression. So like aripiprazole, like many other atypical antipsychotics, with the exception of lurasidone, of course, and quetiapine, seem to prevent mania better than it does prevent depression. So with those new data, then here is the here are the recommendations for maintenance treatment. You can see lithium being number one. Then you have quetiapine, valproate, lamotrigine, asenapine made it to the first line because of those new data. And you can see lurasidone plus lithium or valproate is the second line treatment. And the reason is, as we said, it failed on that primary efficacy measure because of study design issues. But as we said in the secondary analysis, particularly in patients with the index episode of depression, it does prevent relapse of mood episodes. So for that reason, we still think it's appropriate to include that as a second line treatment. So with that, let me summarize some key points in terms of the changes in the 2018 guidelines. For acute mania, the main changes are cariprazine has become first-line treatment in the 2018 guidelines. Olanzapine, as we said, has been moved to the second-line category. For bipolar depression, lurasidone is moved up to the first line because of all the studies that I showed you. Antidepressant adjunctive therapy has been moved to second line because of the smaller magnitude of benefit and the risk of switch in the long-term phases. Cariprazine is the second line because we have that new study showing it's effective. ECT is also second line as well. It's moved from third line to second line. Maintenance, asenapine has become one of the first-line treatments, and so is aripiprazole intramuscular. Olanzapine and risperidone are moved to second line because of the metabolic and other considerations, and lurasidone is the second line, particularly for preventing mood episodes in patients with an index episode of depression. Thanks very much for your attention.